Okay, polypoid lesions of gallbladder. So benign masses of the gallbladder are common. So prevalence is around 3 to 12% of the population. Can be divided into two types: pseudopolyps and true polyps. Pseudopolyps can be divided into the four types: cholesterol polyps, focal adenomyomatosis, hyperplastic polyps, and inflammatory polyps. Cholesterol polyps appear as pedunculated echogenic lesions of the gallbladder. They are usually less than 1 centimeter and multiple. Alternatively, adenomyomatosis are sessile lesions and common in the fundus and characteristic microcysts within the lesion and is frequently larger than 1 centimeter. So this image shows adenomyomatosis, an arrow mark is showing microcysts, which is like a sessile fashion. So difference between cholesterol polyp and adenomyomatosis is cholesterol polyp is less than 1 centimeter, pedunculated echogenic lesion. Adenomyomatosis is more than 1 centimeter and it is sessile lesion, not pedunculated. So that is the main difference. So they have elaborated only these two. Next, true polyps. True polyps are benign growths in the wall of the gallbladder and consists of only 5% of polypoid disorders of the gallbladder. True polyps may be difficult to differentiate from adenocarcinoma preoperatively due to imaging limitations in detecting mural invasion. This is discussed further in malignancy. So as asymptomatic lesions less than 1 centimeter, that is less than 10 mm, with no risk, no other risk factors and no ultrasound features suggestive of malignancy, they can be observed with serial ultrasound. So this is the management protocol for polyps. Any polyp less than 1 centimeter and no risk factors for malignancy and no ultrasound features for malignancy can be only observed. So next is biliary, benign biliary mass. So benign biliary masses are benign intraluminal lesions of the biliary tract, have been a constant evolving field. So the most acceptable categorization is intraepithelial and intraductal. So there are two types. Intraepithelial lesions are described in different grading systems of the biliary intraepithelial neoplasms. These are considered precursor epithelial malignancies of the bile duct. The intraductal lesions are described as intraductal papillary neoplasms. So intraductal or intraductal papillary neoplasms. So that is, they'll project like a wart. So these lesions include mucin-producing neoplasms, adenoma, papilloma, and papillomatosis. So they have only elaborated the intraductal type. So there are mucin-producing adenomas, papillomas, and papillomatosis. Some of these lesions are pre-malignant, including mucin-producing and papillomatosis. The presentation is that of biliary obstruction with jaundice, sometimes right upper quadrant pain. Treatment consists of complete resection with small rim of normal epithelium, because incomplete excision of affected epithelium carries high risk of recurrence. So approach is transduodenal approach. So rarely intraductal papillary mucin-producing lesions may be found in intrahepatic biliary radicals. So inflammatory lesions of the biliary tree, known as pseudotumor or benign fibrosing disease, may be mistaken for cholangiocarcinoma. When this process follows surgical intervention on the biliary tree, mass-like structure may be the result of ischemia to the duct with subsequent inflammation and fibrosis. Alternatively, pseudotumors may occur de novo. These commonly affect the extrahepatic biliary tree above the bifurcation. So pseudotumors are nothing but inflammatory masses. So they are not tumors. Only inflammation and fibrosis will make them appear like tumors. So mostly they will occur in post-operative setting, but in de novo setting also in the extrahepatic biliary tree near the above the bifurcation, pseudotumors can occur. So that is the summary for benign tumors of gallbladder. So now going to the surgical aspects. So I'm audible, right?
Yes, sir.
Screen is visible.
Yes, yes.
Okay. So lap cholecystectomy was first done by Eric Muhe. So his full name is Eric Muhe in 1985 using a direct scope, and later in 1987 by Moret. So Muhe and Moret, these two names are important, and here is also important. So it is one of the most common performed procedures by general surgeons. So laparoscopic cholecystectomy has 0.1 to 0.5% mortality and 2 to 3% morbidity. So this percentage is also important. So most of the morbidity of laparoscopic cholecystectomy occurs in the acute setting in case of acute inflammation, and the studies have shown that laparoscopic cholecystectomy for acute cholecystitis may carry longer operative time and higher conversion to open. So just a minute. So higher conversion to open and longer operative time is in the acute setting. And there is also higher risk for common bile duct injury. So Other causes for morbidity in laparoscopic cholecystectomy is doing cholecystectomy in end-stage liver disease patients with portal hypertension, in cases which preclude safe portal dissection, and in patients with coagulopathy. So most pneumoperitoneum laparoscopies are performed under CO2 and has a number of adverse physiological effects. So what physiological effects is mostly the most common is bradycardia. So that will be dealt in the basic chapters. So see here, COPD with poor availability for gas exchange and congestive cardiac failure are considered relative contraindications. So it's not only absolute contraindication for lap chole is inability to tolerate GA. So all the other cases, even end-stage liver disease, portal hypertension, and coagulopathy, COPD, every patient we can do. But 1 minute, Arun sir is calling. Hello, sir. Okay, sir. Okay, sir. Okay. So next is the standard way. We should know the 4 ports where all we are putting the ports. So usually one large port will be used as the extraction site, typically placed around the umbilicus, and other 3 5 mm ports or even smaller ports for dissection. So 1 10 mm, 3 5 mm ports. After establishment of pneumoperitoneum with CO2, brief exploration is performed, and additional 5 mm ports are placed in the right anterior axillary line, right midclavicular line, and subxiphoid location. The lateral port, that is in the anterior axillary line, is used to elevate the fundus of the gallbladder towards the right shoulder. So that is the first port function of the lateral anterior axillary line port. So this retraction provides exposure to the infundibulum and porta hepatis. So next, midclavicular port. Midclavicular port is used to grasp the gallbladder infundibulum and retract it infralaterally. So this action of retracting infundibulum infralaterally will open up the Callet's triangle. So by distraction of the Hartmann's, that is by pulling the infundibulum infralaterally, the cystic duct is no longer parallel to the common hepatic duct. So the cystic duct will come perpendicular. So it will be separated from the common hepatic duct. So this maneuver will avoid injury. So this is a very important retraction. So next is most important critical view of safety. So what is critical view of safety? It is rotating the gallbladder infundibulum laterally and medially. And there should be only 2 structures entering the gallbladder, and the liver on the opposite side of the gallbladder should be seen. So this is the critical view of safety. They are shown in the image 55.39, and the ports are given in this above image. So next, all these, there is no particular MCQ topic, just see the images. So next is any stones that are spilled during cholecystectomy, what we should do? We should not leave it. So we should try maximum to retrieve all the stones that have been spilled during cholecystectomy. So next is about routine cholangiogram. Just like we saw in the beginning of the chapter, basic points. There is no recommendation for routine cholangiogram, only for selective cholangiogram. So routine cholangiography will identify unsuspected stones in less than 10% of patients only, and does not decrease the incidence of biliary injury and can be misinterpreted. So these are the disadvantages. So we are not recommending routine cholangiography. So Tokyo guidelines does not encourage the use of routine cholangiography. So who said not to use routinely is the Tokyo guidelines. So next is laparoscopic ultrasound. Laparoscopic ultrasound, what the problem is, it is highly operator dependent and requires additional instrumentation in addition to the instruments normally used for cholecystectomy. So that is the disadvantage of laparoscopic ultrasound. So next, one important MCQ, bailout procedures. So there are 3 grades, 3 types, 3 grades of cholecystitis from grade 1, 2, and 3. Laparoscopic procedures become increasingly difficult in the grades. So Tokyo guidelines recommends few bailout procedures. So what are the bailout procedures? The common bailout procedures include subtotal cholecystectomy by fundus first approach, that is retrograde and conversion to open. So subtotal cholecystectomy is removing as much gallbladder as possible from the fundus to the infundibulum and is reconstituting or fenestrated approach. So reconstituting means after doing subtotal cholecystectomy, we will close the gallbladder remnant. Fenestrating is we will just leave the gallbladder remnant open. without closure of the internal opening, with or without closure of the internal opening of cystic duct. So that is the two types: reconstituting subtotal cholecystectomy, fenestrated subtotal cholecystectomy. So you can remember this like this. So if we leave the gallbladder open, we will fenestrate it using cautery. So that actually that image is given in Fisher cooperative surgery book. So that's why it's called fenestrating type of subtotal cholecystectomy. So other is reconstituting. Reconstituting, we reconstitute with sutures and close the gallbladder remnant. So next, fundus first procedure. It is used. It is referred to separation of the gallbladder from the liver surface, starting from the fundus, without visualizing the cystic duct and artery. This procedure can end with subtotal cholecystectomy or complete cholecystectomy. So next is lap. Lap is over. Open cholecystectomy. So open cholecystectomy is one MCQ point is early identification and ligation of cystic artery limits the blood loss during the procedure, but may prove difficult because of inflammation. So earlier identification of the cystic artery is difficult, but if we do that properly, we can prevent blood loss. This approach must be used with caution as the extension of the dissection continues inferiorly, putting the portal vein and other portal structures at risk. So because cystic artery, what is the branch, which is the branch of cystic artery? Cystic artery arises from which artery?
Right hepatic artery.
Okay, so not only right, as we know, there is a lot of variations. It can also arise from many other arteries. So it is very close to the portal structures. So that is the difficulty in doing the cystic artery first approach. So it may injure the portal vein or other portal structures. So next, open CBD exploration. So open CBD exploration, what is the preferred incision? Preferred incision is right upper quadrant incision. And upper midline incision can also be used, but preferred is upper right quadrant, right upper quadrant. So similar to this thing, when we do gallstone ileus, we should put a proximal incision and we have to milk the stone backwards. Similarly, here also in the bile duct, we should put an incision and the offending stone should be milked backwards. And stay sutures are then placed in the choledochotomy, and the choledochotomy is performed in a supraduodenal bile duct. So we can only do choledochotomy and exploration in the supraduodenal bile duct because behind the duodenum, the bile duct, we can only expose it using cauterization. So next, T-tube should be placed and a cholangiogram should be obtained before closing to document clearance of all the stones. So with dilated bile duct, multiple distal impacted stones, distal stricture and stones, intrahepatic stones or primary bile duct stones, drainage procedure will provide more successful outcome. So what are the cases where we do drainage procedure is all these cases: dilated bile ducts, multiple impacted stones, distal stricture, intrahepatic stones, and primary duct stones. So other cases we can only do a choledochotomy and we'll just put a T-tube and we can come out. So next, options, the difference between choledochoduodenostomy and Roux-en-Y hepaticojejunostomy. So one important difference, we all know it is Sump syndrome. So next is side to side or a end to side choledochoduodenostomy allows future endoscopic interventions of the upper biliary tree. So that is one advantage of choledochoduodenostomy. We can do ERCP and we can any further problems in the future we can deal with it endoscopically. But for hepaticojejunostomy we can't do that. We can't do endoscopic interventions. So that is another difference. So next, one more thing is one more surgical option is transduodenal sphincteroplasty. So for which patients this procedure is done? So this transduodenal sphincteroplasty is done for patients with impacted stones at the ampulla, which cannot be retrieved to choledochotomy, or several stones impacted in a non-dilated tree, non-dilated bile duct. So how we do this transduodenal sphincteroplasty? After completion of cauterization, longitudinal duodenal incision is made on the lateral wall. So this longitudinal incision only in the duodenum, and ampulla is incised at 11 o'clock position. So this is very important. Why we should use 11 o'clock position? It's because pancreatic duct will enter in the 5 o'clock position. So it is kept as a standard. If we put the incision at 11 o'clock position, we will avoid injury to the pancreatic duct. So next is another important is, it is important to remember inferior pancreatico-duodenal arcade is adjacent to the distal part of the ampulla. So that is a very important thing. We should not injure the inferior pancreatico-duodenal arcade during sphincterotomy. Then it will lead to hemorrhage. So then what we should do is the duodenal mucosa is sewn to the bile duct mucosa with what is the suture material? Suture material is absorbable 40 or 50 suture. That is 40 or 50 vicryl, like that. Any absorbable suture material should be used for the mucosa, duct mucosa anastomosis. And a 1.5 centimeter sphincterotomy is usually sufficient to allow stone removal and subsequent drainage. So how we should close the duodenotomy? So we should close the duodenotomy in a transverse fashion. So this will avoid duodenal stricture. So that's what's shown in the image. So next is the disadvantage of choledochoduodenostomy. So as we all know, it is sump syndrome because food will enter into the anastomosis and it will get collected in the distal aspect. So next, intrahepatic stones. So intrahepatic stones, we can do a transhepatic approach. And the transhepatic approach to cholangiography is generally more successful. Percutaneous drainage catheters may be left in place and upsized to perform percutaneous stone extraction. So just like we used to see this in hydatid cyst. So we'll upsize the catheters up to a particular point where the tract becomes dilated and we can remove the stones from that tract. So it is a long staged procedure. So next is choledocoscopy. The choledocoscopy at the time of drainage procedure ensures removal of all current stones. This approach allows a stone clearance rate of more than 90%. So this is the transduodenal sphincterotomy, which is being shown on table view. This is the animated view. So you have to open it in the longitudinal direction and close it in the transverse direction. So next is laparoscopic CBD exploration. So laparoscopic CBD exploration, it is to explore the CBD for stone removal and the transcystic approach and choledochotomy. So two approaches are there. So one is after doing cholecystectomy, we can enter through the cystic duct, and another is we can do choledochotomy and enter through the CBD. So Seldinger technique, after balloon dilation, a flexible choledocoscope or alternatively a flexible ureteroscope is passed through the cystic duct. So that is the transcystic technique. Seldinger technique should be used, and wire basket is passed to snare the stone and remove it. So next is choledochotomy approach. Choledochotomy, longitudinal incision is made in the CBD below the cystic duct, and the size of the incision should be at least as large as the diameter of the largest stone. So we should remove the stones and we should close it with a T-tube. And the bile duct, it is closed using 40 absorbable, similar suture which is used for bile duct to duct mucosa anastomosis. So same suture. So next is, this is important, contraindications to transcystic approach. So what are the contraindications? So numerous stones, more than 8 stones, stone larger than 1 centimeter, intrahepatic stones, cystic duct that does not allow dilation, and choledocoscope passage. So there are a few values we have to remember. 8 stones, stone larger than 1 centimeter, intrahepatic stones. So next is post-cholecystectomy syndromes. So post-cholecystectomy syndromes, it was first described in 1947. It is the recurrence of heterogeneous symptoms similar to those experienced before cholecystectomy, such as upper abdomen pain, dyspepsia, with or without jaundice. It occurs in 10 to 15% of all cholecystectomies. So it is a little bit of very common problem. So whatever, if you are doing 100 cholecystectomies, 10 to 15% of patients will be having this post-cholecystectomy syndrome. It's very troublesome. So it can, another important MCQ is, it can manifest from 2 days up to 25 years. So even 25 years after our cholecystectomy, they will come back with pain. So that is the problem, and it is most common in females than males. So what are the few causes? So causes are retained stone, bile salt induced diarrhea, biliary leak, long remnant cystic duct, or functional problems with the biliary tree or sphincter of body, like sphincter of body dysfunction, anything like that. So these are the only few causes. Other causes are idiopathic. We don't know the reason. So next is coming to the most important topic of the entire chapter, bile duct injuries. So I'm audible, right? Clear?
Yes.
Yeah. Okay, so this is the most important topic. We have to read this topic fully, line by line. So first is bile duct injuries. So more than 80% of bile duct injuries occurs during cholecystectomy. So most common cause for bile duct injury is cholecystectomy. The variable anatomy, porta hepatis inflammation, inappropriate exposure, inadequate experience, and aggressive hemostasis have been cited as risk factors. So aggressive hemostasis means aggressive attempts at trying for hemostasis, putting clamps here and there like that. So studies have suggested that misperception, so this is an important word, misperception of the anatomy is a much more common factor in iatrogenic injury than surgical skill. So they may ask MCQ true or false statement like this. They may ask surgical skill is the most important risk factor. We may think it is correct, but it is not correct. So misperception of the anatomy is the most important, most common factor for iatrogenic injury rather than the surgical skill. So another one is with sufficient cephalad retraction of the gallbladder, the cystic duct overlays the common hepatic duct running in the parallel path. So without infralateral traction, so that's what I told in the starting. So that infralateral traction of the Hartmann's or infundibulum is very important. That will only separate the cystic duct and the hepatic duct, or else it will be parallel with the hepatic duct and we may injure the hepatic duct along with cystic duct. So that is important. And then another thing is 30-degree laparoscope. 30-degree laparoscope, nowadays we are using only 30-degree laparoscope. So 30-degree laparoscope is adequate for visualization of the CVS, critical view of safety. So another word is confirmation bias. So in many cases, a confirmation bias occurs in which surgeons tend to rely on evidence that supports their perception, while simultaneously discontinuing visual cues that suggest alternate explanation. So this what they are saying is a confirmation bias. We'll be biased. We'll think that what we are cutting is the cystic duct, but it may be the CBD, but we will think it is the cystic duct. So that is called confirmation bias. But there might be some clues which will give us a visual clue that it is not the cystic duct, but still we'll avoid those clues and we'll think that is the cystic duct and we will cut it. So that is the confirmation bias. So misperception of the anatomy and confirmation bias. So these are the two important terms in this paragraph. Next is confirmation bias helps explain why most of the bile duct injuries are identified post-operatively. So this is the important point. So because of confirmation bias, we won't identify intraoperatively. We will only identify the injury post. We'll think we did it properly, but we will see the result only post-operatively. So next is Bismuth classification, very important classification. So it is Strasberg modification of Bismuth classification. So this is the Bismuth classification in the diagram. So type A, it is the cystic duct leak, cystic duct blowout. And another thing is duct of Lashka leak. Duct of Lashka leak will also come in the cystic duct, I mean type A. It is from the cystic bed, gallbladder bed. So this is cystic duct leak and duct of Lashka leak is type A. And also if the clip is not tight and if it falls off, it is also type A. So type B is we will ligate the cystic duct along with the right posterior sectoral, aberrant right posterior sectoral duct. So in type B, the patients will have posterior sectoral duct which is getting connected to the common hepatic duct. So we will also ligate that duct. So important MCQ in type B is the only type where there is no actual bile leak. It is only injury. So that is important MCQ. Only in type B there is no bile leak. So type C is we will cut the right aberrant posterior sectoral duct. And type D injury is lateral, it's a circumferential injury of the common bile duct. So that is type D. And based on the location of the type D injury, there is 5 Strasberg. This is the E1, E2, E3, E4, E5. This is the Strasberg modification of Bismuth. So what are the types of type D? So E1 is the injury 2 centimeters away from the bifurcation. E2 within 2 centimeters of the bifurcation. E3 is at the level of bifurcation. E4 is stricture formed at the bifurcation which separates the left and right hepatic duct. And E5 is there is a injury to the right posterior sectoral duct with stricture at the near the bifurcation. So these are the 5 types. Actually in Bailey there is one more type. There is also E6. So I'll send the image from Bailey today. So this is the Strasberg classification. So that's what given inside. So next is presentation. So when will the patients present? So there are
E6
cystic
duct. E6.
E6 ஒன்னு இருக்கு சார். அது actually Bailey கொடுத்திருக்காங்க.
Cystic duct.
Okay. So 2 types of presentation. One is recognized at the time of surgery. Other is recognized after surgery. So what is the incidence? So less than 10% of strictures are found in the first week post-operatively, and more than 70% are diagnosed within 6 months. So most of it are delayed presentation only. So if it is diagnosed at the time of cholecystectomy, what we will do? So we have to see what type of duct it is, what is the size, what is the diameter of the duct, what is the size of defect, everything we should, what is the circumference of injury, we have to see what are all these parameters. So if a duct is injured less than 3 mm diameter duct, but it is not caused by electrocautery, that is important point, because electrocautery injuries, it will spread and it will cause widespread injury. So if it is not due to electrocautery, if it is a sharp cut to a 3 mm duct, which involves, if it is less than 3 mm, we can ligate it. But if it is larger than 3 mm, it is not caused by electrocautery, it is less than 50% circumference of the wall, we can place the T-tube through the injury, which is sufficient. Nothing else we should do, which is sufficient. Choledochotomy usually will heal along with without the need for a drainage procedure. So if it is less than 3 mm, we can ligate. If it is more than 3 mm, we have to see whether the circumference is less than 50%. If it is less than 50%, more than 3 mm duct, we can just put a T-tube. Okay. So this is what I said. Duct smaller than 3 mm, we can simply ligate. So next is any thermal injury, that is using electrocautery, any injury is there in which the extent of the thermal damage may not be manifested immediately. So that is the problem. Immediately we won't know how much is damaged. It will later on only manifest, or an injury involving more than 50% of the circumference. It requires resection anastomosis. So resection anastomosis we can do, but if the defect is smaller than 1 centimeter near the hepatic duct bifurcation, it can be mobilized and anastomosed. But if it is bigger defect, more than 1 centimeter defect, it needs biliary enteric anastomosis. So next is trans-anastomotic placement of T-tube. That should also be done. So this is what it's given. More than 1 centimeter defect, then we should do a anastomosis to the GIT. So next, lower injuries to the bile duct can be reimplanted into the duodenum. So that also we can do, polytocoduodenostomy. Next, Roux-en-Y approach is substantially more versatile and can be applied to injuries throughout the biliary tree. In addition, most injuries to the bile duct occurs higher in the biliary tree close to the hilum, thus not allowing tension-free anastomosis. So in case of distal injuries near the duodenum, we can easily do polytocoduodenostomy by the tension-free manner. But if it is high proximal bile duct injuries, we cannot do polytocoduodenostomy in tension-free manner. So we have to do Roux-en-Y hepaticoduodenostomy. So another one point is trans-anastomotic stenting. We should do or not. So what they are saying is trans-anastomotic stenting has been shown to improve the patency with longer duration of stenting, providing more favorable outcome. So trans-anastomotic stenting has been proven to increase the patency. So another MCQ which we used to get during the PG entrance time is, if the surgeon is inexperienced, what we should do. So if inexperienced surgeon, you just place a drain and refer. So that is another point. So next is next important topic, identified after cholecystectomy. So after cholecystectomy, how it can present? So it can present as bile leak. So bile leak can be formed as a bilioma in the subhepatic region, or sometimes it can be it can lead to hemodynamic instability, and it can also lead to biliary peritonitis and draining of the bile through the surgical wound. So all these are the various presentations after cholecystectomy. So, so in the setting of bile duct injury, 20% or more patients will have concomitant unrecognized vascular injuries. So nearby the blood supply to the bile duct will also be injured. So most of 20% of cases will be having vascular injuries. So there are 3 goals. First goal is control of infection. So we have to put the broad spectrum antibiotics to cover all anaerobes, aerobes, and most common bacteria like Enterococcus, E. coli, everything. And in addition, the retraction of the injured bile duct into the hilum of the liver, as well as inflammation in this region, makes successful repair in the immediate post-operative setting unlikely. So that's why if the patient is diagnosed after cholecystectomy and if he is stable, we can do delayed repair. That is only best. But only for patients who are hemodynamically unstable, we will immediately repair. So second goal is clear and thorough delineation of biliary anatomy with cholangiogram. So we have to do proper cholangiogram, or nowadays we can do ERCP, and it can demonstrate the extrahepatic biliary tree, which part is injured, which part has a stricture. So all those we can delineate properly. Small bile leak with bile duct continuity and cystic duct stump leak can be successfully managed by just stenting and sphincterotomy. So that will not cause any problem. Only sphincterotomy will be needed. So last goal, the third goal of management is to re-establish durable biliary enteric anastomosis. So these are the three goals you can see here. So control of infection, limiting inflammation, parenteral antibiotics, percutaneous drainage of the periportal collections, and clear and thorough delineation of anatomy is the second goal. So MRCP or PTC and ERCP, especially if cystic duct stump leaf is associated, ERCP and stenting will be enough. And last is enteric continuity, tension-free mucosa to mucosa anastomosis or through-and-way hepaticogeneostomy, and long trans-anastomotic stent if bifurcation or higher is involved. So that is also important. So next here we can see one PTC being performed, and there is leak, and JP drain is kept. So know the name, Jackson Pratt drain, JP drain. So it is present at the time of initial operation. So this image is a common bile duct iatrogenic injury where PTC and subsequent ERCP both are done. Both are done. The ERCP is guided by the PTC because of the distorted anatomy. So when anastomosis is within 2 centimeters of the
randomized procedure.
Okay, sir. Randomized procedure, both PTC and ERCP. Okay. So next is when anastomosis is done within 2 centimeters of hepatic duct bifurcation. That is for proximal injuries, very proximal near the bifurcation, or involves intrahepatic ducts. Some evidence suggests that long-term stenting may improve patency. So as we saw earlier, trans-anastomotic stenting will improve patency for long-term patency for this high or proximal lesions. So CBD or common hepatic duct more than 2 centimeters from the bifurcation, stenting is not necessary. So for distal lesions more than 2 centimeters from bifurcation, no need stenting. So this is important MCQ point for who needs stenting and who don't need stenting. So next, once identified above the stricture. So now we are coming to stricture. So once bile duct is injured and we are leaving it for stricture formation for delayed repair. So once the stricture is formed and identified, only a limited segment of bile duct less than 5 mm is dissected free. So why they are doing this? So as we know, the blood supply to the bile duct comes from the lateral side, 3 o'clock and 9 o'clock position. So when we dissect more than 5 mm on both sides, there is risk of injury to the blood supply to the bile duct. So we should not dissect for more than 5 mm on both sides. So any further dissection of normal duct tissue risks vascular compromise of the segment to be used in anastomosis. So if the vascular tissue is compromised, then anastomosis will not take. So that is the problem. So another one more important point is mucosa to mucosa anastomosis can be created by end to side fashion to the Roux-en-Y jejunal limb in the setting of inflammation. So instead of end to end, we can also do end to side. So in the setting of substantial inflammation at the bifurcation, another reconstruction option involves anastomosis of the Roux-en-Y limb to the left hepatic duct. So if we can't make out the common bile duct or common hepatic duct, we can also anastomose to the left hepatic duct. So the liver will entirely drain through the left duct. So next is intervention radiology and endoscopic techniques. So in the பயங்கர மழை எல்லாம் கேக்குதா ஒழுங்கா வாய்ஸ் எல்லாம் பிரேக் ஆகல கேக்குது சார் okay. So next, intervention radiology and endoscopic techniques. So fluorescence guided management using percutaneous access to traverse the stricture can be used when the duct continuity of the duct is preserved. So what are the techniques? Balloon dilation. Balloon dilation is successful in 70% of patients. So for which patients we can do this intervention techniques? It is reserved for those with primary bile duct strictures or patients who have undergone choledochoduodenostomy for reconstruction. So in these patients, we can do endoscopic, but we can't do it for Roux-en-Y hepaticogeneostomy. So main MCQ is for primary bile duct stones, strictures, primary strictures. So next is outcomes of repair. So biliary enteric reconstruction after bile duct injury with many series has shown more than 90% patients free of jaundice and cholangitis. So 90% patients are symptom free. So sepsis at the time of reconstruction and biliary cirrhosis are predictors of strictures. So if there is sepsis at the time of reconstruction, post reconstruction there will be stricture and cirrhosis. So chronic liver disease and hepatic fibrosis are associated with higher operative mortality. So these are all points which we know, but just for completion's sake. So next is biliary leak. Biliary leak is usually due to an unrecognized duct of Lashka leak. So it is type A, type A Strasbourg. So fever, chills, right upper quadrant pain, jaundice, leak from the incision or leak into the drain, persistent anorexia or bloating are all common signs and symptoms. So similarly, as we saw earlier, acute cholecystitis carries greatest risk for bile leak. So patients generally present within 1 week of cholecystectomy as the bile collects and becomes clinically manifested. So most of these leaks are within 1 week they manifest. So CT should be done, and after drain placement and controlling the leak infection, endoscopic cholangiogram should be performed. If the leak is from a cystic duct stump, sphincterotomy is enough. So if you only do sphincterotomy, and cystic duct stump will heal. So next point is if
sphincterotomy with stenting.
Sir?
So sphincterotomy with stenting.
Sphincterotomy with stenting. Okay. So if percutaneous drainage is not feasible because of overlying bowel or fluid, or the fluid is not localized and thus not amenable for percutaneous drainage, laparoscopic washout can be given. So if percutaneously we can't do it, we can do laparoscopy. So no attempt should be made to fix the leak, because any intervention is almost always unsuccessful and carries risk of further injury to the biliary tree. So we should only control the sepsis and we should do delayed repair. So what time we can do the repair? So bile leak longer than 6 weeks should raise suspicion of unrecognized bile duct injury. So similarly, CBD injury, surgical treatment of bile duct is most successful once the inflammation has resolved. So actually, Rajamahendran notes, sir has given us after 8 weeks. 8 to 12 weeks, we can do repair.
Yes, sir.
Okay. So next is lost stones. So lost stone is accidental opening of the gallbladder with spillage of stones, which occurs. It occurs in 20 to 40% of cases of cholecystectomy, especially during lap. So pigmented stones, a high number of stones, less experienced surgeon performing the surgery, severe cholecystitis are all risk factors for losing stones. So delayed consequences. What are delayed consequences? Is chronic abscess, fistula because of erosion, wound infection, and bowel obstruction. So most drop stones, which is the most common site of drop stones. So it is the Morrison's pouch, that is the hepatorenal pouch, or retrohepatic space along the abdominal wall. So this is the most common site, Morrison's pouch. The likelihood for the development of abscess in this the development of complications from lost stones is difficult to quantify, because surgeon documentation of gallbladder perforation is variable and substantial delay frequently exists between cholecystectomy and complication from lost stones. So most cases, because of the delay, we won't associate it with lost stones. We will think it is due to some other reason. And one more important MCQ, if there is a lost stone, should we convert to open? So lost stone does not necessitate conversion to open. We can retrieve using lap itself. And important thing is we should counsel the patient after lap that stones have been lost, and there can be possible delayed presentation. So documentation and counseling the patient is important. So we should tell them abscess might form in the future. So next is post-cholecystectomy pain. So post-cholecystectomy pain, so mostly it is due to secondary choledocholitis or bile leak. So most common reason is that. Other reasons are sphincter of body dysfunction, functional causes like that, and post-operative bile duct strictures. So these are few causes. And other causes of right upper quadrant pain should be investigated, like any other differential diagnosis, diabetic ulcer, duodenal ulcer, like that. So next is retained stones. So what is retained stones? Stones identified up to 2 years is retained stones. After 2 years is recurrent stones. So hyperbilirubinemia, elevated alkaline phosphatase with the previous surgery history, we should suspect retained stone. So ultrasound may not show intrahepatic biliary duct dilation if the stone does not fully occlude the duct. So ultrasound we cannot rely for the diagnosis. We can do endoscopic removal of these stones to generous sphincterotomy, and it is most universally successful. So retained stones, first intervention is ERCP. So next is cholangitis. So cholangitis, mostly all the points which we know only they have told. So we'll see this image. So this image is important, very important. Every image in hepatobiliary is important. So this is a cystic duct stump leak, which is shown in the arrow. So this is the retained stones. We can see the arrow mark is showing stones in the common bile duct, which is retained. So next is cholangitis. So cholangitis is due to ascending bacterial infection. So that is very important. It is due to bacterial infection from the bowel, which ascends into the CBD. So obstruction from a stone, bacteria is identified in 90% cases. So when the stone gets obstructed, 90% cases we will have bacteria in the bile. So that is bacteria. So most common organisms, as usual, Klebsiella, E. coli, Enterobacter, Pseudomonas, and Citrobacter, all these. And Charcot striate, we all know very well. So 50% of patients, but it is seen in only less than 50% of patients. Fever, jaundice, right upper quadrant pain. And among these three, jaundice is the least common finding. We will get pain and fever, but jaundice we won't get in all cases. So that is important. This 50% is also important. Only in less than 50% cases, Charcot striate will be completely seen. So HIDA scan, acute cholangitis is just like acute cholecystitis condition only, but it involves the bile duct. So HIDA scan can be done. So HIDA scan should be interpreted with caution because infection of the biliary tree reduces the secretion of these agents into the biliary tree. So in HIDA scan, the secretions, this thing, agent will not get into the bile duct. So it will be like a acute cholecystitis picture. So next, most valuable modalities are ERCP and PTC. So we have to do this to relieve the obstruction so that the septicemia will not occur. So endoscopic or percutaneous drainage. If endoscopy is unsuccessful, then only we should think about surgery because cholangitis, most patients will be very sick. They will not tolerate the surgical procedure. So only if endoscopic procedures fail, we should do surgical drainage and placement of T-tube. Surgical treatment of the cause is deferred until the patient is stabilized. So only we should do drainage by surgery, keep T-tube and come out. And we have to treat the cause only after patient is optimized and stabilized. Just drink some water. Sir, okay, then are there additional points?
இல்ல இது ஓகே தான். அதுலயும் டோக்கியோ கைட்லைன்ஸ் இருக்கு.
டோக்கியோ கைட்லைன்ஸ் அது டெய்லி
இதுக்கும்.
Okay, sir. So next, recurrent pyogenic cholangitis, RPC. So it is most common. This already Satya has told in the liver chapter. So we just see few important points. It's most common in East Asia, and recurrent pyogenic cholangitis is caused by cholangiohepatitis or intrahepatic stones. So because of intrahepatic stones, there is recurrent cholangitis which occurs. So the biliary pathogens, the parasites which are seen are Clonorchis sinensis and Ascaris lumbricoids. So these are the two important. And the stone which is formed is brown pigment stone, because any stone which forms in the setting of infection or retained stent is brown stone. So brown stones are formed here. So next is the chronicity of the infection and inflammation places these patients at the risk of development of cholangiocarcinoma. So because of chronic inflammation and infection, RPC is a pre-malignant condition. So we should treat them promptly. Recurrent pyogenic cholangitis tends to occur in the 3rd to 4th decade, and men and women are equal. So this is important. So in only few conditions we will see men and women are equal. So one of that is RPC. And lobar or segmental atrophy or hypertrophy may be seen in chronic cases. So in case of acute attack, conservative treatment should be done with parenteral antibiotics, IV fluids. Only when this fails, we should do ERCP in acute. So only for chronic, we should do ERCP or surgery. For acute, mostly it is conservative. If this fails, we have to do ERCP and we have to remove the stones. So definitive operative treatment is almost always required, because once it becomes chronic, we should remove it, or else it will lead to cholangiocarcinoma. So what are the goals of surgery? So 3 goals. First goal is remove all the stones. Second goal, bypass, enlarge or resect the strictures. And third goal is provide adequate drainage. So strictures are the point where the malignancy will develop. So it should be resected, because it can be a differential diagnosis for malignancy. So the presence of intrahepatic strictures connotes a complicated case and may warrant resection, stricturoplasty or hepaticojejunostomy. So next is, there is something called access loop. So the terminal end of the root limb of hepaticojejunostomy should be brought out like a stoma, so that we can, in future, if it comes as recurrent disease, we can introduce a polydocoscope and we can remove the stones. So disease affecting predominantly one lobe should be resected. So this is the principle throughout hepatobiliary. If one lobe of the liver is identified, one lobe is only involved, we can do hepatectomy. Whatever may be, even if it is for a simple abscess, we can do hepatectomy. So that is the one principle.
அதுதான் ஹென்லிஸ் லூப்.
Okay, sir. So name of the access loop is Henle's loop.
அப்புறம் இந்த எந்த லோப் என்ன வரும், ரைட்டா லெஃப்டா?
இதுல ஆக்சுவலா அது ஸ்பெசிஃபிக்கா கொடுக்கல சார்.
சரி.
So next gallbladder cancer. So gallbladder cancer is a very important topic for entrance. So, numerous questions. This last NEET also 2 questions came repeated. Same question was repeated twice in the last NEET, and few questions also came. Totally 4-5 questions from gallbladder cancer came. So each and every line is important. So incidence of gallbladder cancer. So gallbladder cancer generally occurs in 6th and 7th decade of life, and 2 to 3 times more common in women. And it is more common in women in India and Pakistan, and also in Latin America and Native American immigrants from Latin America. So cause we will see all the risk factors. So what are the risk factors for gallbladder cancer? So gallstone is the primary risk factor, and stones larger than 3 centimeters carry increased risk of cancer development. So this is why for prophylactic cholecystectomy we saw one point. If the stone is more than 2.5 centimeter, we should do prophylactic cholecystectomy, even if it is asymptomatic. So this is the reason, because more than 3 centimeter stone, it is a risk for gallbladder cancer. So it's very important. So next, more than 80% of patients with gallbladder cancer have gallstones, and gallbladder cancer is approximately 7 times more common in patients with gallstone than those without. So each and every percentage is important. 80% cases will have gallstone. It is more than 7 times common in those without gallstones. And next important is type of stone does not correlate with incidence of gallbladder. Every stone has equal incidence. So other risk factors are chronic inflammation like APPJ, choledochal cyst, primary sclerosing cholangitis, and the one we saw just now is that is for cholangiocarcinoma. Primary sclerosing cholangitis and recurrent pyogenic cholangitis also for cholangiocarcinoma. For gallbladder cancer, primary sclerosing cholangitis will come. So other is extensive calcification of the gallbladder, termed as porcelain gallbladder. So next is malignant disease in the setting of porcelain gallbladder is less than 10%. So next is no evidence of patients with gallbladder polyposis carry an increased risk of gallbladder malignancy. So that is also one more thing. So if the gallbladder polyp is more than 1 centimeter and carries increased risk of malignancy, cholecystectomy should be done. So this is the repeated point again from this thing, polyps topic. So if it is more than 1 centimeter, we have to do cholecystectomy. So next, staging. Staging is it spreads via lymphatics, so that is not and through surgical wound tracks and biopsy it will spread. So types of gallbladder. So this is actually gross types are infiltrative, nodular, papillary, and combined forms. So in this infiltrative, the most common is infiltrative pattern, and it spreads in a subserosal plane. So that is very important. Subserosal plane. This entire paragraph is important. Infiltrative is the most common type. It spreads in the subserosal plane. It can invade the entire gallbladder wall and even into the porta hepatis. Next, nodular types tend to grow as a more circumscribed mass and can invade the liver. So nodular type, we will think it is a circumscribed mass, but it can invade the liver. So that is also dangerous type. So only papillary type is a good prognosis. It carries better prognosis and tend to have indolent course and are commonly limited to the gallbladder wall at the time of diagnosis. So another is mixed type. So infiltrative is the most common type. It can spread subserosally and it can infiltrate anywhere. Nodular type is circumscribed type, but still it can invade the liver. Papillary type, it is the best prognosis, but it is very rare type. So that is the problem with gallbladder cancer. Only the most aggressive type is common. So first, draining nodal basin for gallbladder, where it goes first. So first is to the cystic and pericholedochal. So around the cystic duct and the bile duct. So from these, the primary draining areas. So from cystic and choledochal, it goes to retroportal, pancreaticoduodenal, and then to celiac, superior mesenteric, and finally to aortocaval nodes. So this is the route of spread of lymphatics. So this is very important. Cystic, pericholedochal, then retroportal, pancreaticoduodenal, then celiac, superior mesenteric, finally aortocaval. So coming to gallbladder anatomy, pathophysiology. So what is the thing is, it will have very narrow lamina propria and only single muscular layer. There is no serosa, no submucosa. So easily the tumor will spread easily into the liver and easily outside the gallbladder. So that is the important thing why gallbladder invades early. Invades early. So direct venous tributaries to the liver parenchyma, these tumors spread directly into segment 4 of liver. So without direct invasion through venous tributaries also, it will go and spread into the segment 4 of the liver. So presentation, clinical features, 90% they originate from the fundus and body. This is also in situ. Most common site of gallbladder cancer is fundus or body. So most of the patients, 30%, 35% will present with nodal disease, 40% will present with metastasis. So almost half of the gallbladder cancers, they will come to us with metastasis. So it is a very bad disease. So that's all just a story only. So diagnosis, we have to do CEA and CA 19-9. So that is very important. They are elevated. So ultrasound findings of gallbladder cancer is irregular shaped lesion in the subhepatic space, heterogeneous mass in the gallbladder lumen, asymmetrically thickened gallbladder wall, finding of a polyp larger than 1 centimeter should raise suspicion. So heterogeneous mass, irregular shape, subhepatic space, asymmetrical wall thickening, and polypoid lesion more than 1 centimeter. CT MRI is also important. And so PET is a valuable tool for searching for metastasis, because as we know, 40% cases will come to us with metastasis. So we should find out where the metastasis, we can use PET. And gallbladder has tendency to seed the biopsy. So what is the indication for biopsy in gallbladder cancer? So if it is a resectable disease, we should not do biopsy. It is contraindicated. Only if it is unresectable disease or incurable disease, we can do biopsy for confirmation, and then we can go for palliative care. So that is very important MCQ. So we'll see the images and staging. So staging is very important. So TX, no evidence of tumor. TIS, carcinoma in situ. So T1, T2. So in other cases like bowel and all, we'll see T1 is mucosa, submucosa, T2 is muscularis. But here T1 itself, it's up to muscular layer. So T1A involves the lamina propria, and T1B invades the muscular layer. So T1B itself, muscle is gone. So next is T2. T2 is very important. T2 is involvement of perimuscular connective tissue on the peritoneal side without involvement of the visceral peritoneum, or tumor invading the perimuscular connective tissue on hepatic side with no extension to liver. So that is A and B. So B is on the liver side but without involving the liver. A is on the abdominal side without involving the serosa or the visceral peritoneum. So T3 is very important. T3 is the involvement of the liver. So it perforates the serosa, directly invades the liver, and or one other adjacent organs such as stomach, duodenum, colon, pancreas, omentum, or extrahepatic duct. So liver with one extrahepatic organ is T3. T4 is main portal vein, hepatic artery, or two or more extrahepatic organs. So that is T4, very important. Main portal vein, hepatic artery, two or more extrahepatic organs. So what are the extrahepatic organs? Stomach, duodenum, colon, pancreas, omentum, extrahepatic bile ducts. So nodes are easy. So N1 is 1 to 3 nodes, N2 is more than equal to 4 nodes, and M0, M1, only 2 M stages. So next is this grading is also given. Grades well differentiated, moderate differentiated, poorly differentiated. So coming to the images, all these images are cancer. So first image is, there is no extraluminal extension. It is only inside. The wall is not involved, because we can make out the entire boundary of the wall. But 55.57, the ultrasound, it shows loss of continuity of the gallbladder wall and the arrow suggesting extraluminal growth. So we can see the posterior shadow. The wall is not completely intact. So tumor has invaded the wall. So here we can see a gallbladder cancer invasion into the duodenum. And here we can see the main portal vein, invasion into the portal bifurcation. Arrow mark is showing there. So next we are going to the treatment, very important for NEET SS, treatment of gallbladder cancer. So depending upon the staging. So 4 specific subgroups are there. So patients with gallbladder polyp, patients with incidental gallbladder finding at the time or after cholecystectomy, patients with suspected of having gallbladder cancer preoperatively, and patients with advanced disease. These are the 4 groups of patients we will encounter. So first is gallbladder polyp. So polyp, same point only, again they're telling, single polyp greater than 1 centimeter, older than 50 years age, all those we have to do surgery. So we can do laparoscopically itself, no need to do open. Polyps smaller than 1 centimeter can undergo surveillance to demonstrate stability, with the exception and setting of primary sclerosing cholangitis. So for primary sclerosing cholangitis, if patient has polyp, even if it is less than 1 centimeter, we have to do surgery. Other cases only more than 1 centimeter, we can do surgery. Up to that, we can wait. So next is gallbladder cancer after cholecystectomy. We are doing cholecystectomy and report comes as malignancy. So these cases, the good thing is that they'll have good prognosis because we will detect early. So mostly it will be a T1 or T2 lesion only. So if it is a T1A lesion, only for T1A lesion, cholecystectomy is enough because only the lamina propria is involved, T1A. It does not involve the muscular layer. So cholecystectomy will be sufficient for a good margin. Next is T1B. So another important point is we should see the cystic duct margin. If it is margin positive, we should again resect. And we should, if necessary, we can resect the CBD to obtain negative margins. So next for T1B lesions, it is controversial. Some are telling cholecystectomy is enough, but some say we should do extended cholecystectomy along with removal of the liver. So T1B lesion, so again, they came to a conclusion. If T1B lesion is having perineural invasion, lymphatic or vascular invasion, the likelihood of nodal disease is increased. Therefore, extended cholecystectomy is done. So this is one point. So if it is aggressive T1B, we should do extended cholecystectomy. So what is extended cholecystectomy? So removal of the gallbladder, draining lymph nodes, hepatoduodenal, gastrohepatic and retroduodenal lymph nodes, and resection of the cystic duct margin to uninvolved mucosa may require resection of the CBD with Roux-en-Y reconstruction. So because local extension in the hepatic parenchyma is common, 2 centimeter, apparently normal hepatic parenchyma from the gallbladder fossa is resected. So margin, what is the liver margin? 2 centimeter margin. And liver, what segments we will resect? So that is not given clearly. It is segment 4 and segment 5B. Because segment 5B and 4 forms the gallbladder bed. So next is port site excision. This is also controversy. So port site recurrence rarely occurs in isolation and may represent aggressive disease. So in patients with T2 lesions, in which cancer extends past the muscularis but not beyond the serosa, radical cholecystectomy is indicated because next is from T2 lesions onwards, it is always radical cholecystectomy. If it goes beyond the muscularis up to the subserosal region, which is T2, we have to do extended radical cholecystectomy. So residual disease after operative intervention predicts poor outcome. Sir, the port site recurrence பத்தி ஒன்று சொல்லுவாங்கல்ல, நம்ம ரொட்டீனா எடுக்க வேண்டாம், only if ஏதோ prognostic மட்டும் we can.
Port site recurrence already it is a metastatic disease.
Okay, okay, sir.
So it is of no use அப்படின்னு சொல்லியிருக்காங்க. Port site disease தான் metastatic disease தான். அதனால
கீமோதெரபி
அதனால பெருசு. ஆமா.
palliation. இதுல அவங்க ரொம்ப கிளியரா கொடுக்கல, ஜஸ்ட் ஒரு லைன் கொடுத்துட்டு விட்டுட்டான். So next, suspected patient suspected of having gallbladder cancer preoperatively. So this is preoperatively we have diagnosed gallbladder cancer. This survival is poor because these patients will come at an advanced stage. We won't detect it early. So patients may require extended liver resections. Operation begins with the diagnostic laparoscopy. So diagnostic laparoscopy, just like stomach, if we see peritoneal deposits and hepatic metastasis, we will abandon the procedure. We can avoid laparotomy. So actually that there is 1%, 37 to 38% laparotomies are avoided because of diagnostic laparoscopy. This, I think it's given in notes. So that is important percentage. Because of advent of diagnostic laparoscopy, we are avoiding 37% laparotomies. So next is radical resection in the setting of T3, T4 includes segment 4B, segment 5. More often, it requires a central hepatectomy, which includes 4, 5, and 8. So central hepatectomy means 4 on the left liver and 5 and 8 segment on the right liver. So that is central hepatectomy. So direct extension of the tumor into adjacent structures such as hepatic flexure is not a contraindication to resection as long as negative margins can be obtained. So the principle for gallbladder surgery is, or if we can obtain negative margins, it is not a contraindication. We can go ahead and resect how much ever we want. So debulking, but the other point is debulking without the possibility of complete resection has no role in the management of gallbladder cancer. So debulking has no role. Only if we can resect the entire disease with negative margins, we have to go ahead for aggressive surgery. So advanced disease As usual, it is palliation. Metal stents are used, self-expanding metal, not plastic, metal stents. So next is percutaneous neurolysis of celiac ganglion. So celiac ganglion block can be given, celiac plexus block for the pain. And chemotherapy. Chemotherapy and radiotherapy are not effective and has not shown a survival benefit. So adjuvant therapy, when we should give adjuvant therapy? So majority of gallbladder cancer recurrence occurs at distal sites. So distant metastasis is the most common form of recurrence. So for metastatic setting only, we should give gemcitabine based chemotherapy. Another is patients with high risk lesions, T4 tumors, positive lymph nodes, R1 resection should be considered for adjuvant chemotherapy. Otherwise, chemotherapy has no role, no neoadjuvant, no nothing. Only for these metastatic lesions or lesions which are aggressive. Next is survival. Survival depends on the stage. So stage is the most important prognostic factor. So other independent factors affecting survival are T stage, N stage, histological differentiation, CBD involvement, R0 resection. So next is metastatic disease. The median age of survival is only 13 months. So only 1 year. So next final topic, last topic, bile duct cancer, cholangiocarcinoma. So cholangiocarcinoma, it is the second most common primary cancer of the liver after hepatocellular carcinoma. First is hepatocellular carcinoma, second is cholangiocarcinoma. So 2/3 of the lesion will occur in the proximal biliary tree, that is Klatskin's tumor, hilar cholangiocarcinoma or Klatskin's tumor. So risk factors, already we have seen the risk factors: chronic inflammation, which is choledochal cyst, and toxic pancreatic secretion, that is abnormal pancreaticobiliary junction, all the pancreatic secretion coming to the bile duct. And this thing, we saw the recurrent pyogenic cholangitis due to Pronorchis sinensis, Opus sorcis viverni, and primary sclerosing cholangitis. Primary sclerosing cholangitis is the most common risk factor for cholangiocarcinoma in the West. So US and all, US, UK, most common it is primary sclerosing cholangitis. So another important point, sporadic for cholangiocarcinoma and primary sclerosing cholangitis, cholangiocarcinoma. What is the difference? So for sporadic cholangiocarcinoma, they tend to occur at the bifurcation. So patients with sporadic will have at the hilum, at the bifurcation. Patients with primary sclerosing cholangitis will have multifocal disease, not amenable to resection. So multifocal diseases with primary sclerosing cholangitis, sporadic will be at the bifurcation, just like a Klatskin tumor. So another risk factors are smoking, thorodrast, oral contraceptives, asbestos. And finally, cirrhosis. Cirrhosis is also important risk factor, like biliary cirrhosis and all those. So here staging, here also like gallbladder, there is 3 types: sclerosing, nodular, and papillary. Gallbladder we saw infiltrating, nodular, and papillary. Here sclerosing, nodular, and papillary. So here the most common is sclerosing out of the 3. Just like gallbladder, how it is infiltrating, here sclerosing is the most common. And nodular and papillary subtypes are 2 types. But here actually there is one confusion. Sir, Arun sir, the common type is papillary கொடுத்திருக்கு. But ஆனா Bloom-Gart Shackelford ரெண்டுத்துலயுமே வந்து nodular தான் common.
Sclerosing.
அது sclerosing வந்து most common sir. But அடுத்த nodular and papillary-ல most common வந்து இதுல வந்து papillary கொடுத்திருக்காங்க. Nodular and papillary. அது ரெண்டுத்துல வந்து nodular தான் most common ட்டு Shackelford, Bloom-Gart எல்லாம் கொடுத்திருக்கு. So அதே ஃபாலோ பண்ணலாம்.
ஆமா.
பெய்லில பார்த்தேன், பெய்லில இத பத்தி எதுவும் ப்ராப்பரா கொடுக்கல.
அதாவது கேட்க மாட்டாங்க, ஆனா நோடுலர் தான் மோஸ்ட் காமன். அதுக்கப்புறம்
நோடுலர். ஓகே, சோ மோஸ்ட் காமன் ஸ்க்ளீரோசிங், அதுக்கு அடுத்தபடியா நோடுலர். ஓகே, சோ நெக்ஸ்ட் வந்து there are 3 types: intrahepatic cholangiocarcinoma, hilar cholangiocarcinoma, and distal CBD cholangiocarcinoma. So the 2 pathological factors mostly influencing prognosis are complete resection and negative margins and absence of lymph node mets. So இதெல்லாம் தான் prognostic factors. So clinical features: painless jaundice is most common symptom. So unilobar obstruction of the bile duct may present with unilateral lobar atrophy. So that is very important. If there is only unilateral atrophy, it is a resectable lesion. We can go ahead for hepatectomy. But if there is contralateral, both lobes are atrophied, we cannot do resection. So pruritus, dark urine, that all we know. And we saw gallbladder, it spreads in subserosal route, but cholangiocarcinoma, it spreads in submucosal route. So that is a very important difference. So diagnosis and assessment of resectability. So how we'll assess whether it is resectable? So first we have to do basic investigations, prothrombin time, albumin level, all those, and the CEA, CA99, just like gallbladder, and right upper quadrant ultrasound. So with the hilar cholangiocarcinoma, gallbladder is visualized and extrahepatic biliary tree is usually decompressed with distal lesions. So if distal lesions are there, we should decompress the bile duct, or else it will go for cholangitis. So gallbladder distension and cross-sectional imaging by triple phase CT allows not only assessment of metastatic disease but also evaluation of resectability. So what is the investigation of choice for evaluation of resectability of cholangiocarcinoma? It is triple phase CT. So that's a very important one-liner. So in detection of aberrant anatomy, segment or local involvement, CT is helpful. So everything CT only. So CT alone, typically CT alone is insufficient for the assessment of feasibility and appropriateness of resection. Cholangiography by MRCP, ERCP may be needed. So if we cannot do it with CT, we can use MRCP or ERCP. So next is bilobar intrahepatic metastasis and any extrahepatic disease or contraindications to resection. So as I said, bilobar involvement is contraindication for resection, and involvement of bilateral secondary radicals, that is also contraindication for resection. And next contraindication is encasement of main portal vein, bilateral hepatic lobar artery involvement, and lobar atrophy with involvement of contralateral portal vein. So if one lobe is atrophic and same portal vein is atrophic, we can resect the lobe. But if one lobe is atrophic with contralateral portal vein involvement, then it is a bilateral disease, so we can't. So second order radicals, everything is these are all the contraindications for surgery in cholangiocarcinoma. So again, tissue diagnosis, just like gallbladder, we don't need biopsy, it is unnecessary. And with obstructive jaundice, bile duct cytology and brush border cytology are unreliable. So negative cytology report, we should not exclude malignancy. Even with malignancy, we can get negative cytology report. Next, another very important MCQ is above what level of bilirubin we should do stenting. So biliary drainage is generally not needed, because if we do ERCP and stenting and then if we do surgery, it will cause infection, surgical site infection. But for cases with bilirubin more than 10, we have to do stenting. And if there is prolonged interval between presentation and resection, still we have to do stenting. So these are the two indications for stenting in cholangiocarcinoma. So next, treatment of cholangiocarcinoma. So between 7 and 15% of patients undergoing resection for suspected biliary malignancy will prove to have benign disease. So problem is, most of the imaging, it will show benign disease also like malignant disease. So 7 to 15% of patients will be having benign disease only after resection. So for distal cholangiocarcinoma, Whipple's pancreatic duodenectomy should be done. So again, they are saying the lesion grows in the submucosal plane. R0 resection is the most important prognostic factor. For gallbladder, the stage of the disease is most important prognostic. Here, R0 resection. So 5-year survival for R0 resection up to 50% in node negative. So even with R0 resection, node negative patients, only 50% will survive. So even cholangiocarcinoma is very aggressive disease. So proximal cholangiocarcinoma, like hilar cholangiocarcinoma. So there is one classification called Bismuth-Charlotte classification. So this is the Bismuth-Charlotte classification. Type 1 is below the bifurcation. Type 2 up to the bifurcation. Type 3A is beyond the bifurcation on the right side. Type 3B is beyond the bifurcation on the left side. And type 4 is on both sides. So using this, they can form one MCQ. Actually, this was asked in the question bank. So lesion, type 3A lesion with left side atrophy or left side portal vein involvement, is it resectable? So answer is it is not, because in type 3A, right side duct is involved and question has given left side portal vein involvement. So it is a bilateral disease. Similarly, they'll ask in type 3B Charlotte with right side portal vein involvement. So type 3B means left side duct is gone and question giving right side portal involvement means it's unresectable. So they can confuse you like that. So this is a very confusing part if they ask like that in the question. Classification is very easy. So right side is type 3A, left side is type 3B. So if we remember that, we can crack the question. So next is type 1 and 2 lesions are treated with common bile duct excision. Just a minute, I'm getting a phone call. Hello? Okay. அப்படியா? ஓகே ஓகே. ஓ சரி சரி. ஓ ஓகே ஓகே ஓகே. எல்லாம் சேர்த்து. ஸோ நீங்க இந்த சென்ட்ரல் ஜிஹெச் கூப்பிட்டு போறீங்களா அங்க நம்ம மெட்ராஸ் மெடிக்கல் காலேஜ்? அங்க ஆமா, ஆக்சுவலா அம்மாட்ட வேணா கேட்டு பார்க்கலாம். அப்படியா, அவங்க வண்டி ஓட்டிட்டு இருப்பாங்கன்னு நினைக்கிறேன். ஆமா ஆமா. நீங்க அதான் அப்ப அங்க ஆக்சுவலா நல்லா தான் இருக்கும். அங்க அங்க ஆக்சுவலா அங்க இன்னொரு டாக்டர் எனக்கு தெரிஞ்சவங்க இருக்காங்க அந்த டிபார்ட்மெண்ட்ல. அங்கதான் சென்ட்ரல் ஜிஹெச் நம்ம மெட்ராஸ் மெடிக்கல் காலேஜ்னு சொல்லுவாங்கல்ல. அதான் ராஜீவ் காந்தி ஜிஹெச், சென்ட்ரல் ரயில்வே ஸ்டேஷன் ஆப்போசிட்ல. ஆமா ஆமா ஆமா. அப்ப அங்க கூப்பிட்டு போயிருந்தீங்களா? ஆமா ஆமா. நீங்க கூட ஒரு டைம். ஆமா 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 ஆமா. கரெக்ட் கரெக்ட். ஆமா ஆமா. அவங்க இருக்காங்க. பிளஸ் அங்க இன்னொரு இப்ப பிஜி பண்ற டாக்டர் எனக்கு தெரியும். அந்த கார்டியாலஜிலே பிஜி பண்றாங்க இப்போ சென்ட்ரல் ஜிஹெச்ல தான். ஆமா ஆமா. நீங்க அனுப்புங்க. ஆமா, இப்போ ஒரு கிளாஸ் போயிட்டு இருக்கு. நீங்க வந்து ஆமா உடனே கூப்பிட்டு போங்க. நான் கிளாஸ் முடிச்சு நான் திருப்பி உங்களுக்கு கூப்பிடுறேன். ஆமா, எல்லாமே இப்ப எடுத்த எல்லா ஸ்கேனுமே எடுத்துட்டு போங்க. அனுப்புங்க அனுப்புங்க. ஓகே ஓகே ஓகே. இல்ல இல்ல, அங்கெல்லாம் நமக்கு செலவாகாது. ஆமா ஆமா ஆமா. இவங்க அந்த காப்பீடு திட்டம் ஏதாவது வச்சிருக்காங்களா? ஓ, காப்பீடு இல்லையா? ஓ சரி 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 சரி. ஓகே ஓகே ஓகே. அங்க வந்து இந்த அளவுக்கு ஆகாது. உங்களுக்கு சப்போஸ் காப்பீடு இல்லைன்னா கூட இவ்வளவு ஆகாது. நான் அதான் இந்த கிளாஸ் முடிச்சுட்டு நான் உங்களுக்கு கால் பண்ணி நான் கேட்கறேன். காப்பீடு இல்ல என்ன பண்றது என்னன்ட்டு. நீங்க ரிப்போர்ட் அனுப்புங்க. ஒரு 20 மினிட்ஸ்ல கால் பண்ணுங்க. சரி சரி. ஓகே. Okay, sorry for the inconvenience. So next is Bismuth-Charlotte classification. Type 1, type 2 lesions are treated by common duct resection. So only duct resection is necessary for type 1, type 2 lesions, and then we can do 2-way hepatic ileostomy. So margins they are given. Margins 5 to 10 mm margins of resection is needed. So there for gallbladder we saw 2 cm liver margin. Here we should give up to 1 cm margin of resection should be given. If lesions may also require partial hepatectomy. So type 2 lesions may require hepatectomy because it is near the bifurcation. So type 3, type 4, they involve complex resection with reconstruction of the portal vein, hepatic artery or both, with resection of the secondary biliary radicals and transanastomotic stenting. So just like that we saw before, if the biliary structure is high above, transanastomotic stenting is better. So here also, after resection for cholangiocarcinoma, stenting is important. So negative margin status is the most important for outcome. So we saw in the last page, R0 resection is the most important for cholangiocarcinoma. So next MCQ point is benefit of routine lymph node dissection. So this is also important. There is no survival benefit. There is only prognostic information we can get from nodal dissection. So they will ask in true or false statement. Nodal dissection will improve survival. It is a false statement. It will only be prognostic use. So next is neoadjuvant. So previously noted extensive neoadjuvant therapy protocol followed by transplantation in the setting of underlying disease. So they have tried neoadjuvant chemotherapy and transplant for the cholangiocarcinoma, but this is still experimental because most of the cases they have got recurrence. So it is only under trial for transplant for cholangiocarcinoma. So next palliation for this thing, metastatic disease, same only like for relief of jaundice we should put metallic stent. For duodenal obstruction also we can do duodenal stenting. If ERCP cannot be done, PTC can be useful for more proximal lesions. And medical treatment. So here also chemotherapy and radiotherapy is not routinely used. Both of them are not useful for gallbladder cancer also, and even for this thing cholangiocarcinoma only surgery. Surgery can only give some benefit. So only in patients with, just like gallbladder cancer they are telling here, only for nodal disease and R1 resection chemotherapy is better. So outcomes of survival, long-term survival is highly dependent on stage at presentation and complete surgical resection. So gallbladder it is mostly stage. Here stage and R0 resection. So 5-year survival is very less. Only 20 to 45% is the 5-year survival. So very aggressive tumor. So next is distal common bile duct cancers. Resection rates are higher. So distal CBD cancer, just like Whipple's, it will present early, so we can resect them at earlier stage. And median survival for unresected patients is only 5 to 8 months. So total hepatectomy and transplant. So total hepatectomy, unfortunately, this initial experience with therapeutic transplantation was plagued with early mortality and high recurrence. So that's what they have. They're only doing it in clinical trials because of recurrence. So metastatic and other tumors. So other tumors are the most common example is portal nodal disease from adenocarcinoma, such as hepatocellular carcinoma, pancreatic adenocarcinoma, and colorectal carcinoma. So these metastatic portal nodes, they will compress the CBD and they will cause jaundice. Another one is lymphoma. Lymphoma will also compress the CBD by the portal nodes. So it is difficult to differentiate from cholangiocarcinoma. And another thing is, one point is temporary placement of stents, plastic stent. So if it is a metastatic cholangiocarcinoma where we need permanent stenting, we will use metal stents. Here in this case of lymphoma, plastic stents are enough because lymphomas will respond to chemotherapy. So after giving chemotherapy, the obstruction will get relieved. So in those cases, only plastic stents are enough. So that is one MCQ point. So last point is intrahepatic biliary cystadenomas and cystadenocarcinoma may obstruct the bile duct and directly to passage of the mucin they produce. So actually here cystadenoma and cystadenocarcinoma, they have given in notes. I'll put the images. Here they have not given elaborated on this. So that's all chapters over. I'll just show the staging. So staging for intrahepatic bile duct cancer. So intrahepatic bile duct cancer. So T1 is solitary tumor without vascular invasion, less than 5 centimeter, or more than 5 centimeter without vascular invasion. Less than 5 centimeter is T1A, more than 5 centimeter is T1B. So T2, solitary tumor with intrahepatic vascular invasion or multiple tumors with or without vascular invasion. So if it is a single tumor with vascular invasion, it is T2. And if it is multiple tumor, even without vascular invasion, it is T2. So T3 is perforating the visceral peritoneum. T4 is extrahepatic structures by direct invasion. So nodes are easy. No nodes are only nodes. So 5 centimeters is the cutoff for staging, and vascular invasion is the another cutoff. So this is for intrahepatic. So next for hilar cholangiocarcinoma. So hilar cholangiocarcinoma also staging is very important. So T1 is involvement confined to the bile duct with extension up to the muscular layer or fibrous tissue. T2 is important. T2A, T2B. T2A, tumor involves beyond the wall and to the surrounding adipose tissue. T2B is it involves the adjacent hepatic parenchyma. So gallbladder, we saw T3 was involvement of hepatic parenchyma. Hilar cholangiocarcinoma, T2B is involvement of hepatic parenchyma. So that is the difference. We just highlight this. So T3, tumor invades unilateral branches of portal vein or hepatic artery. T4, main portal vein, common hepatic artery, all those, and second order biliary radicals. So we saw second order biliary radicals is contraindication to resection. So that all comes under T4 disease, contralateral portal vein, hepatic artery involvement, all that. So nodes are easy, 1 to 3 nodes. That is the perihilar nodes, cystic duct nodes, common duct nodes, hepatic artery, posterior pancreaticoduodenal artery, portal vein nodes. All these will come in N1. N2 is 4 or more, and the nodes described in N1. So if it is 4 or more, it is N2. So next is for distal bile duct cancer. Here the cutoff is important. So T1 is less than 5 mm depth of invasion. T2 is 5 to 12 mm depth of invasion. T3 is greater than 12 mm depth of invasion. So tumor involves the celiac axis, SMA and or common hepatic artery, then it is T4. So this millimeter depth of invasion is only important. And others N1, N2, just like before, 1 to 3 nodes, 4 or more nodes. So that's all. So Arun sir, the chapter கொஞ்சம் சுருக்குன மாதிரி தான் இருக்குல்ல சார், இன்னும் கொஞ்சம் பாயிண்ட்ஸ் இருக்கு.
இது இருக்கு, இது மாதிரி கேட்க முடியாது, இதே கொஞ்சம் எக்ஸ்பென்சிவாக தான் இருக்கு. இல்லைன்னா கொஞ்சம் எக்ஸ்ட்ரா மேயா போட்டு கரெக்டாக டிரான்ஸ்பிளான்டேஷன் அதெல்லாம் இருக்கும்.
ஓகே சார், ஓகே சார்.
வேற ஐஹெச்சிசியும் இதுவும் கொஞ்சம் இன்ட்ராஹெப்பாட்டிக் கொலாஞ்சி கஷ்டமா இருக்கு. அதுலேயே வந்து 2 டைப் கொலிஷன் டியூமர், ஹெச்சிசி ஐஹெச்சிசியும் ஹெப்படோசெல்லுலர் கார்சினோமா டிஃபரன்ஷியேட் பண்ணுறது, அது இதில் அது தேவை அவ்வளோவா. இது கொஞ்சம் நல்லா தான் கொடுத்துருக்கேன். நான் வேறு எதாவது இருந்தால் போட்டு அனுப்புறேன்.
ஓகே சார். நான் அந்த பெய்லி நானும் அனுப்பிடுறேன் சார். ஆக்சுவலி நேற்றே அனுப்பினேன் சார், மறந்துட்டேன். பெய்லி ஃபோட்டோ அனுப்பிடுறேன். ஓகே சார். தேங்க்யூ சார். தேங்க்யூ சத்யா.
தேங்க்யூ.
ஓகே சார்.